Thank you, Doctor. Thanks for the Kuwaiti Gastroenterology Association for this invitations, and we're happy to be here with you. Now we will start the inflammatory bowel disease sessions, and we'll start with Prof. John Marshalls. Prof. John Marshalls is a well-known international IBD expert worldwide, coming from McMaster University in Hamilton, Canada. He trained lots of IBD specialists in the Gulf region, in Saudi Arabia and Kuwait and other cities. And we're happy to have him today. Today, Dr. Prof. Joe Marshall will talk about management of structuring in Crohn's disease. Prof. Marshall, stage is yours.
Well, thanks very much for that kind introduction, and thank you for allowing me to be back here in Kuwait. It's great to catch up with some trainees, some colleagues, and certainly some friends here, and I've enjoyed it very much. And I'm happy to speak to you a little bit about strictures in Crohn's disease, and I'm going to show you briefly my conflicts of interest. But this image tells you that I'm very used to the pain of being behind an obstruction. And this is my drive to the airport 2 days ago. And the pain of being behind an obstructive stricture is really real in Canadian traffic, as it is in Crohn's disease. But we're talking about Crohn's disease strictures here, and these are common phenomena in our patients with Crohn's disease. At diagnosis, maybe 20% of patients will have a stricture. A lifetime prevalence of stricture in people with Crohn's disease is approaching 50%. And the patients we see with internal penetrating disease invariably have a stricture as the source of that internal penetration. And so these patients can present with obstruction. They can also present with penetrating complications, including abscess. Important to remember that colonic strictures can be associated with cancer. And over 10 years of follow-up of a colonic stricture, that rate of malignancy might approach 5%. Strictures are probably the main cause of disease-specific hospitalization in patients with Crohn's disease and the main cause of surgical resection. And to date, we have no therapies that specifically and directly address fibrosis, although that may change in the near future, and we'll come back to that. I think it's worth noting that our classification systems, the Vienna and Montreal classification systems, really do a disservice to strictures because we think of those behavioral categories, the non-inflammatory, the inflammatory B1, the fibrostenotic B2, and the penetrating B3. As soon as patients become B3, that trumps, and I use that word very carefully, B2. So a lot of the patients with penetrating disease, in fact, have underlying fibrostenotic disease, and so we can very easily underestimate its prevalence. So how do strictures form? Well, the pathogenesis is complicated and probably poorly understood, but the first point here is probably the most important, that it's an interplay of both inflammatory pathways and non-inflammatory pathways, that is, direct fibrogenic pathways, and both can occur. There's an aberrant deposition of extracellular matrix, there's hyperplasia of the smooth muscle, and there are a number of mediators which have been identified which could be potential therapeutic targets in the future. Some interesting papers recently, one identifying the bacterial flagellum as a potential antigen driving the fibrogenic response of patients with Crohn's disease, and just even more recently, a wonderful paper from Florian Rieder in animal models suggesting that the creeping fat in the mesentery may be driving stricture formation through fatty acids, and I think that's a whole other avenue of potential therapy that will be pursued. We also know that there's a genetic component to this. A number of cohorts have identified NOD2 as a genotype, the mutant alleles that predict the clinical phenotype of stricturing Crohn's disease. And all these individual cohorts are fairly consistent, pointing to a significant odds ratio increase in the risk of various complications of Crohn's disease, including fibrostenosis, if you carry a NOD2 genotype. So certainly that may play a predisposing role in patients with Crohn's disease. No matter how you get to the stricture, no matter what the mechanism is, at the end of the day, strictures are a prominent part of our rating systems for disease activity and severity. And those of you doing endoscopy in IBD patients, I'm sure you've used to reporting the SCSCD score, and of course the presence of a stricture, presence of multiple strictures, and particularly impassable stricture, have a big component of these disease activity indices. So we do think they're significant in terms of assessing disease activity. One limitation of the SCSCD is that it rates and weights each colonic segment and ileal segment equally in terms of the calculation of the full score. So my colleague Niraj Narula at McMaster with us has developed an alternate tool for assessing disease activity endoscopically in patients with Crohn's disease, which is the SCSCD, the modified multiplier SCSCD. And really what this outlines or emphasizes is that strictures in different segments may have different significance in terms of prediction of subsequent disease course. And if you can't read the font, it's fairly small, but if you look at that red box, ileal strictures are more prognostic than, for example, ascending colon strictures. So I think the MMSCSCD, I think, is getting a little bit of traction. You might see it emerging in clinical trials in the future, but it does its best to weight pathology in different disease segments differently in order to get a more precise estimate of future disease course. But even strictures within a given segment are not all created equal, and this is an example of 3 different strictures, all of which would be considered an impassable stricture in the SCSCD scoring system, but I think we'd approach these very differently. On the left, a stricture which doesn't allow passage of the adult colonoscope, but might allow passage of a gastroscope, so you can certainly get through it to survey the proximal colon. In the middle, a pinhole stenosis, which there's no way of accessing the proximal colon. And on the right, a stricture which is pinhole, but also has a very prominent inflammatory component. And I think all of us may approach each of these in a very different way. So certainly strictures are not created equal. Another thing to remember is that small changes in wall thickness and luminal diameter can have big functional consequences. And this is an image from a review paper from Florian Reeder a few years ago, which gave the example of bowel wall thickness being decreased from 18 millimeters to 15 millimeters. That 17% reduction in bowel wall thickness translates to an over 6-fold increase in luminal area and luminal patency. So very small changes in wall thickness through medical therapy perhaps, very small changes in luminal diameter through mechanical intervention can have significant benefits in terms of function, and just a few millimeters can make a big difference. So how do we classify strictures? This is from a great review from Kathy Liu, who's a fellow Canadian ultrasonographer, who with a consortium, international consortium, developed criteria for ultrasound diagnosis of intestinal strictures, and I know there's some enthusiastic ultrasonographers in the room. And really there are 3 components to this. There has to be luminal narrowing imaging, there has to be an increase in bowel wall thickness, and there should be pre-stenotic dilatation in order to make diagnosis of a clinically significant stricture. This is the example of measurements from ultrasound. There's a very similar paper looking at measurements using MR enterography. So to define a stricture, we really look for these 3 components: wall thickness, luminal diameter, and proximal dilatation. I think ultrasound's a wonderful tool, and in Canada we're a little slower than some other jurisdictions, but we're starting to use this more and more in the clinic to get that more immediate bedside diagnosis of disease activity and specific complications, including stricture. But probably MR enterography has been our workhorse and is arguably the gold standard for imaging stricture in Crohn's disease. I'm not a radiologist, but these are some of the MR criteria that may infer presence of fibrosis in a thickened segment, T2 signaling, delayed gadolinium enhancement, this ADC, apparent diffusion coefficient on diffusion-weighted imaging, and the magnetization transfer ratio as well. All these things by radiologists can be used to infer the presence of fibrosis within thickened and obstructed segment on MR imaging. And you can try to boil these things down to sort of simple rules, and this is an example of a simplified MR classification tool, 2x2 table, using enhancement gain, delayed enhancement gain to being lower or higher, meaning low fibrosis or more fibrosis, and then T2 weighted signal intensity, looking for inflammation low or severe. And I think the key thing to take away from this is these fibrosis and inflammation often coexist, and I think probably the minority of our patients who have a purely fibrotic or a purely inflammatory stricture on imaging. But these sorts of rules can help to tease apart how significant the inflammatory component of a stricture might be. So how do strictures perform over time? This is from a systematic review published a few years ago, which looked at cohorts of patients receiving background systemic immunosuppressive therapy, often biologic therapy. What is the likelihood of progressing to surgical intervention in a patient diagnosed with a clinically significant symptomatic stricture at baseline? And this may be a useful number to carry around. It's 27% from this pooled estimate, so about 1 in 4 patients with a symptomatic stricture will eventually progress to surgery on average. Obviously, there's going to be a lot of variation, some individual patient characteristics that will push that estimate higher and lower, but that's about the number you can think of. About 25% of patients will eventually proceed to surgery. But the question comes, should we be treating patients with stricture more aggressively medically? Should we do something different with these patients in order to avoid surgery, reduce the long-term risk? And really, the one trial we have that's looked at this specifically is Strident, which was published a few years ago. I think many of you will have seen this. This is an open-label trial performed in Australia, looking at patients with Crohn's disease who had either a post-operative anastomotic stricture or a de novo stricture mostly in the small bowel on imaging, and were symptomatic and had evidence of inflammation, elevated CRP, calprotectin, or inflammation on MRI scan. They're randomized to 2 different strategies, either high-dose aggressive adalimumab therapy, you can look at that dosing, 160 weekly for 4 weeks, and then 40 milligrams every 2 weeks with criteria for dose escalation if there's evidence of ongoing inflammatory activity, and that was combined with azathioprine, or using adalimumab at standard dosing. That was the control arm, and it was stratified by whether patients required baseline balloon dilatation, with the primary outcome being an improvement in symptom score. There's patients who went into this trial, so just a few things to point out. About 25% were smokers, and smoking is a risk factor for fibrosis. Almost all of the strictures were ileal strictures. Very few were upper GI or colon. About 20% of patients had a baseline balloon dilation at study entry, so not everybody, about 20% of people did have a dilation, and the mean length of the stricture, the median length, I should say, was about 6 centimeters. So these are fairly long strictures that were treated in this trial. It was technically a negative study. That difference in the score between the green, which was the intensive treatment group, and blue, which is the standard treatment group, not reach statistical significance. But on the right, if you look at the likelihood of progressing to further intervention, that did significantly favor the more aggressive treatment regimen. And if you start to look down into all the secondary endpoints which are analyzed, there's a consistent trend in favor of more intense therapy. And some of these secondary endpoints, including the MRI imaging, did reach statistical significance. So I actually take away that this is probably a positive study, that there may well be value to more aggressive medical therapy of patients who have inflammatory disease and stricture. In my practice, I'm not giving these people 160 for 4 weeks. I'm not following that regimen, but certainly more quick to dose escalate and more quickly to use proactive therapeutic drug monitoring these patients to make sure that I've maximized medical therapy. Another source of data we can look to are post hoc analyses of some of the registration trials which have been done with our existing therapies. This is another paper that my colleague at McMaster, Niraj Narula, led, looking at large clinical trial databases from with infliximab, ustekinumab, and also azathioprine, using individual patient data. And of course, all of these patients had SCSCD scores. So you could pull out the subgroup of patients who at baseline had impassable strictures. And the leftward series of bars there looks at the patients who at baseline had non-passable stenoses. When entering the trial, they received these various medical therapies. And at 1 year, 62% in fact had passable or no detectable strictures. So Again, it's a post-hoc analysis, but it does suggest that with medical therapy, non-passable strictures can regress without surgical or endoscopic intervention. So I think that's useful information. But all of these are really anti-inflammatory therapies looking at controlling inflammatory disease activity, presumably having some benefit by reducing the inflammatory component of wall thickness. What we're looking for in the future is really therapies which can directly affect fibrosis. And we're on the cusp of that. Many of you will know that the next class of therapy to be arriving for treatment of inflammatory bowel disease is really the TL1A antagonists. Their ligand is DR3. DR3 stands for death receptor 3. That can't be a good thing. But this is a good example of a therapeutic class which has anti-inflammatory activity because it has effects on adaptive immunity as well as innate immunity, but has potentially a direct effect on fibrosis. And so this will be the first class of therapy which we think may be direct inhibitors of fibrosis and of stricture formation. So many of you will know these are all in clinical trials. Some of the early results are being presented. And in fact, this is some headlines recently. People are making a lot of money off these potentially as investors. Those of you going to ECHO in a few weeks will see the additional data reported from duvakitug. I'm still not sure how to pronounce that, but the phase 2 clinical data in both the Crohn's disease and UC are being presented at ECHO, and I think there's going to be some very targeted study of stricture formation with this class of therapy. So that's probably just a couple of years away in terms of entering the clinic, and behind that another class of therapy, ALK5 inhibitors, which also seem to have direct effects on blocking fibrosis. This other class of therapy will be coming to the clinics as well. So we may have two different classes of therapy with direct effects on stricture formation. That's really for the future. What do we do today? Well, a lot of us are doing endoscopic interventions for strictures in Crohn's disease. And of course, we have different things available to us. I think endoscopic balloon dilation is probably the mainstay. Is there a role for intralesional therapy? What about stents? What about doing a needle knife stricturotomy? All of these things are potentially within our toolkit. Start briefly with balloon dilation. This is a systematic review looking at outcomes of balloon dilation in patients with stricturing Crohn's disease, and largely it's a mixture of anastomostic and de novo ileal strictures. You can see from the red box at the bottom, the clinical efficacy success in terms of symptom improvement is about 80%. Complication rates may be 2.8% per procedure, but because patients need multiple procedures, it might hit about 6% per patient. That's not all perforation. A lot of that is pain, fever, bleeding. Minority of those patients would really have frank perforation. So probably overall an acceptable complication rate. But the problem is recurrence, and if you look at the box on top there, over 2 years of follow-up after balloon dilation, about 3/4 of patients have symptomatic recurrence, about 3/4 have required repeat dilation, and maybe 40% have progressed to surgery. So still a high likelihood of recurrence. Some technical factors to consider. Usually when you do these procedures, like to have some background cross-sectional imaging, particularly in patients where you cannot see the proximal end of the stricture to really estimate its length or morphology. Balloon dilation we prefer in patients who have shorter strictures, certainly less than 5 centimeters, and I think many would say less than 2.5 centimeters. The outcome, if you look through this entire literature, seems quite similar between anastomotic and de novo small bowel strictures. And a good diameter to aim for is 15 to 18 millimeters. We usually start 1 to 2 millimeters larger than the estimated residual luminal diameter. Dilate for 30 to 120 seconds each time. And we always have this rule of 3, not to be overly ambitious, say no more than 3 dilations at a session, and really don't aim for more than a 3 millimeter gain in terms of diameter in a given session. And the whole concept of intralesional steroid injection is really quite
2 minutes,
contentious.
Dr. John. 2 minutes.
So I'll show you this summary from literature. I won't go through all of it, but really this literature is very poor on this topic. And I think the bottom line from all of this would be that this is not recommended for standard practice. We only have very small clinical trials with conflicting conclusions, so wouldn't be part of our routine care. Just to keep moving, and I think maybe I'll skip that in the interest of time, endoscopic sphincterotomy stricturotomy, I should say, in IBD-related strictures. This was another systematic review. Again, no clinical trials here. This is all observational data. Decent rates of technical success, but significant rates of potential complication, and a lot of these patients do eventually go to surgery. This wouldn't be considered a standard approach to managing strictures. There may be a role in distal rectal strictures, for example, where there's concern for sphincter damage, and patients don't tend to tolerate those dilation procedures very well. So it really would be important for a small subset of our patients. What about stenting? An option is a summary from some of the observational data, high technical success rates. The problem with stenting in the literature has really been stent migration, particularly distal stent migration. If you look cumulatively, it's over 40% rate of distal stent migration using that in Crohn's-related strictures. So it really hasn't found its place as a mainstay, maybe for specific patients with longer strictures where other techniques have failed. There is actually a randomized controlled trial here comparing stents versus balloon dilation in patients who have strictures in Crohn's disease. This was in Spain. I'll just skip to the bottom line, was that there was a significantly better outcome with balloon dilation than with stent. So certainly this, I think, trial supports the idea that our primary modality endoscopically would be balloon dilation. We'd only consider stenting as a second option, particularly in patients where surgical intervention is really not feasible or appropriate. You might want to keep your eyes out for this. This is another Spanish trial which is being undertaken. This is comparing endoscopic intervention for stricture with surgery. So patients being randomized to either undergo resection or either balloon dilation or stent placement. And so this trial is underway in Spain. It should be reported in the next couple of years. I would hope that there be some benefit overall to endoscopic versus primary surgical therapy. That said, there are patients for whom we probably should go more directly to surgery, and this is a risk model which has been published called the Bacardi, looking at factors which may predict eventual surgery, pre-stenotic dilation, CRP elevation, penetrating phenotype at presentation, requirement for biologic therapy, and carrying a nod to risk allele. If you tick all of those boxes, in this analysis, you're 100% likely to eventually get surgery. And even if you hit 4 or 5, then you're about 80% likely. And there's an argument that if you have a high Bacardi score, don't mess around with endoscopic therapy. You might as well just go straight to surgery because the patient's going to get there anyway. Another risk factor not on this slide is stricture length, and there are data to suggest that for every additional centimeter of stricture length, the likelihood of requiring surgery goes up by 8%. So the longer the stricture, also the more likely the patient is to eventually undergo surgery, and probably should do so sooner rather than later. Surgical management can be different things. So we prefer laparoscopic techniques. I'm not a surgeon, so I can't speak to some of the nuances. Obviously, there's a role for stricturoplasty in patients who have more diffuse disease, who've demonstrated rapid recurrence, or are at risk of small bowel. But most of our patients tend to go for resection. There has been some controversy about forms of anastomosis, as many of you will know. Also coming up at ECHO in a few weeks is a paper showing no benefit to the cone-OS anastomosis in preventing recurrence, but still a contentious area. And for some patients with foregut strictures, there may be a role for bypass. So just the last couple of slides. If you look overall at an approach to stricture intervention and management in patients with Crohn's disease, first question is, there is a significant active inflammatory component, in which case you would pursue primary anti-inflammatory therapy. We often give these patients a trial of prednisone to see if the stricture opens up. If that's unsuccessful, if there's no evidence of active disease, then for strictures which are less than 5 centimeters, probably would go on to endoscopic therapy, particularly if there's no angulation, no penetrating disease, no abscess, and no concern for malignancy. Those patients would manage endoscopically. The rest would like to go to surgery. So just to summarize, if you look at our patients with strictures in Crohn's disease, we define the strictures by wall thickness, residual lumen diameter, and presence of proximal dilation. MRI, and it should say, and ultrasound are useful tools to define and characterize strictures. I think we should still consider intense medical therapy for inflammatory strictures. Balloon dilation is an effective tool to restore patency. The other things, stricturotomy, stenting, and use of intralesional steroids are really not considered standards of care, but could be on a case-by-case basis. Consider early surgery for patients at high risk where medical and endoscopic therapy is unlikely to succeed. And I think the future is very exciting with targeted medical therapies in new classes. And I'll just close with another Canadian image where there's no obstruction. There's excellent flow over Niagara Falls. So this is hopefully what we get to achieve in our patients as well. Thank you.
Thank you, Prof. John Marshall. It is now frozen, the Niagara Falls.